White. Let me start with Dr. Kurose. You and I lived through, me much less so than you, all the difficulties of transitioning Coastal Medical to an ACO and to a very successful ACO. But if you look through all those difficulties to the experience of your patients at the end of the day, how do you evaluate Coastal Medical's patient experience as a result of the successful transition?
As somebody who practiced primary care for 20 years and ended that part of my career just as the ACO movement was really getting up and running, the things that I've seen happen at Coastal for patients really go way beyond what I could have imagined. There's a whole variety of centralized clinical programs that improve access to care, timeliness of care. There are disease management programs for specific chronic conditions. There are primary care urgent clinics, nights, weekends, holidays. There is a whole multidisciplinary team available to many of our patients with members of the team, including clinical pharmacists, social workers, navigators, co-located behavioral health providers. And so I look at the movement to accountable care as really being the impetus to allow that great expansion of services to really deliver a level of care that we just couldn't do when I was in practice.
So in order to save the millions for Medicare that Coastal has saved, you were not obliged to cut benefits to your patients. Indeed, they saw new and improved services.
Yeah, I think that's an accurate statement, and we have sort of a truism that we repeated often at Coastal, which is that you have to spend more to save more. So you have to invest in the human and technology infrastructure to really be able to execute on population health management if you want to be able to deliver the kinds of services that we're talking about. But it was the alternative payment models inherent in the ACO model that allowed us to generate that additional revenue, which we then reinvested to fund all that clinical programming, which ultimately improved efficiency, improved care, reduced total cost of care.
The bureaucratic system did not always entirely support that transition. One of the things that I think makes sense in a fee-for-service system is prior authorization, just to keep billings from going through the roof. But once there is, as you say, skin in the game, the rationale for prior approvals in a value-based system appears to diminish, if not entirely evaporate. Were you obliged, nevertheless, to continue to seek prior approvals? And if not, where not, and was that a success?
We certainly did, and Coastal still does see requirements of that type. The sort of interim solution at Coastal was to create teams of people who could assist providers in that process so as to reduce the administrative burden and the time commitment to that particular aspect of the work. But I agree completely with the underlying thesis that when you incent provider organizations to be accountable for total cost of care, then a lot of those, once you have that construct in place, then you may not need to have all these administrative processes. One thing that I'll add is that it's important as we try to build out and execute on these constructs that we remember that the payment model that an organization sees has to be translated into an aligned compensation model for physicians if you really want to lock in that mindset that we're counting on to sort of control avoidable spending and improve efficiency. So knowing that there's alignment between organizational payment models and physician compensation, I think, is important if we expect to see the kind of outcomes you're alluding to.
Last point, if I'm building a house or doing a major renovation, I hire a general contractor to manage the project for me, and I expect that general contractor to intermediate with electricians, drywall folks, carpenters, all the specialists who do the work of bringing the project to a successful conclusion. Is that the way primary care presently works? And would it be useful to try to put primary care providers into more of a general contractor model so that they can intermediate between the patient and the specialists and coordinate care more effectively to the benefit of the patient.
So that's an interesting analogy, and I think that there is a key role for primary care physicians to coordinate care when a patient has multiple complex conditions and requires the care of multiple specialists. I'm not sure all my specialty colleagues would like the general contractor analogy so much, but I think if we could at least agree that what we need is regular communication, and I think the other thing that primary care docs are uniquely positioned to do is to have a deeper understanding of what the patient's own priorities and goals of care are, and in that context, the primary care doc can really help to shepherd the care of a patient through what you alluded to earlier, I think correctly, as a very much fragmented system still and highly complex. For those of us who work in healthcare, even when we have to help a family member try to navigate systems, it's even inside baseball players find it challenging at times. And so I think that's a really important aspect of the role of primary care that we need to preserve and expand.
Senator Grassley.